Good evening, ladies and gentlemen. For those of you whom I have not had the pleasure of meeting in person, my name is Koert Pretorius and I'm the CEO of Mediclinic Southern Africa. It is my privilege to welcome all of you to our panel discussion on national health insurance. We are broadcasting live from our corporate office in Stellenbosch. The release of the NHI Bill on the 8th of August is a very important development in the history of our country. The vision of NHI is to implement a universal access system, universal access to healthcare for South Africa. Many people and organizations support this vision in line with what the World Health Organization is also propagating for countries throughout the world. The current bill, ladies and gentlemen, is a high-level enabling legislation which will establish a framework for the introduction of national health insurance in South Africa. Unfortunately, the bill is vague on some key issues that are of fundamental importance to the future of the entire healthcare system in South Africa. The implications are therefore not clear at this point in time, and this is creating uncertainty and sometimes also negativity. There are many key questions that are still unanswered. For instance, how will the NHI be funded? What will the future role of private healthcare be under NHI? How will the benefits of the NHI fund be determined? How will contracting with public and private providers work? How will tariffs be determined? These are the questions that we will seek to answer this evening. We also want to talk about possible solutions to be developed and, very importantly, how the private provider industry can participate in the development of these solutions. Joining me on the panel this evening, firstly, on my immediate left, is Professor Nicola Tron. Nicola is the Senior Managing Director of FTI Consulting in South Africa. She's an extraordinary professor in economics at the University of Stellenbosch, and Nicola has done a lot of work in the private healthcare industry and supported us as an expert during the health market inquiry. Welcome, Nicola.
Thanks, Koert.
Then, to my immediate right, Dr Anban Pillay. Anban is the Deputy Director General in the National Department of Health. He's got a very impressive CV. In the interest of time, I'm not going to work through his full CV, except to say that national health insurance is one of his primary responsibilities, and we are indeed very privileged to have Anban on our panel this evening. Welcome to you.
Good evening, Koert, and good evening to the viewers.
Thank you. Then, on the right of Anban, we have Rowley Buys. Rowley is the immediate past Chief Strategy Officer of Mediclinic Southern Africa. Rowley retired officially 2.5 years ago, but since then Rowley has been involved as a consultant to assist Mediclinic Southern Africa with important developments in the healthcare industry. Rowley was part of the Ministerial task team that developed NHI many years ago, I should say, and currently he is on the Health Working Committee of Business Unity South Africa, and Rowley is also a member of the PMB Review Committee under the auspices of the Council of Medical Schemes. Welcome, Rowley.
Thanks, Koert. Good evening to everyone, and I apologize for my voice. I had a strange morning this morning where I could hardly speak, but I'll try to do better. Thanks.
Thank you, Rowley. We appreciate your willingness to participate. Rowley developed laryngitis, but Anban assured him that the NHI fund will pay for that, will pay for his treatment. Ladies and gentlemen, you are, of course, welcome to participate this evening. You can text your questions to the following number, 49710. You don't have to type in any preface. You can just SMS whatever questions you want to ask to 49710. Please keep in mind that you should limit your questions to 160 characters. Otherwise, it becomes very difficult to follow the questions. Before we move on to specific questions, I'm going to allow an opportunity for each panel member to make a couple of introductory remarks, which will be very brief, and then we will get into the meat of the discussion. Nicola, can we start with you, please?
Sure. Thank you, Koert, and good evening to all the viewers. I think the point that I would like to make right at the outset to set the scene here is to understand that this NHI Bill, which we have recently seen, is a milestone in a very long road. We've seen the green paper, we've seen two versions of the white paper, and now we see a draft bill here that needs more work, but at least sets the scene for what we expect going forward. And I think it's important to also repeat what Koert has said, that there's no debate any longer that we need to give access to healthcare. There's no debate about the inequality in this country. That's not no longer debated. The issue here is how do we get to that point of equity? How do we use the scarce fiscal resources that we have? And for me, what is important is to think about the complex environment, not to deny the fact that there are many policy processes here, that we're waiting for the Health Market Inquiry report in September. And we don't want to see uncertainty and impact negatively on share prices. So to me, there needs to be some responsibility. There is information available, and I think the aim tonight is to unpack that, also to understand exactly what is certain, what is uncertain, and how should we position ourselves for that.
Thank you very much, Nicola. Anban, can we move over to you?
Thank you very much, Koert. Thanks for the opportunity, and I suppose a big thank you to Mediclinic for organizing this. I think it's really important to have an event like this where you're able to share information, and all of the potential providers in the Mediclinic family as such can raise questions. For me, I think it's important that we appreciate that the NHI is a massive change in the way the health system is going to function from what it is now. And with change always comes uncertainty. And I think we would like to take everyone along with us. We appreciate that there are areas of concern, and our intention is to make sure we engage with everyone, understand what their concerns are, and see how best we can deal with those going forward. The idea is not to alienate the private sector, I think, as some people have said. The intention is to bring the private sector on board so that we have a broad platform of service providers in the health system to deliver services. So we would certainly like to continue to engage with Mediclinic and all of the providers that are contracted through Mediclinic to understand how best we would deliver these services under NHI.
Thank you very much. Rowley, over to you.
My answer would be short and sweet. I think what we really want to see in South Africa is a healthcare system which is fair and available to everyone. But what we want to see is a process which is transparent and fair. And we want to understand what the consequences are if the steps in the program that we follow aren't followed sequentially, that we actually end up with the wrong result. So for me, it's about the planning and the implementation and how well we would do something to get to a goal.
Thank you very much. Ladies and gentlemen, I think all of you will agree with me that the future role of private medical schemes is one of the key issues that need further clarification. So I want to start with a question to Anban on this specific issue. Anban, there are two sections in the bill that speak to the future role of private medical schemes. Firstly, there's section 33, and I want to quote directly from the bill, Once national health insurance has been fully implemented as determined by the Minister through regulations in the Gazette, medical schemes may only offer complementary cover to services not reimbursable by the fund. I think the word reimbursable is key in this context. Then complementary cover is defined as coverage for services not reimbursed. Section 8 states that users are allowed to purchase healthcare through voluntary medical scheme insurance when they deviate from stipulated NHI care pathways. Can you provide us with clarity on these two sections and your understanding on the future of medical schemes and the rights of patients?
I think it's important to first emphasize the point that medical schemes will continue to exist in an environment even when NHI is fully implemented. And our vision at this stage is that medical schemes will provide a complementary cover. And complementary cover, broadly speaking, refers to those services that the NHI will not fund or not reimburse as such. I think the detail about how that would happen and what are the exact services that each fund will cover, etc., would be things that we would work through over the period. You will note in the clause that you read that it's the minister that will introduce regulations, and those regulations will come in at the point when the NHI is ready for implementation. At this stage, our planned date for implementation is 2026. So between now and then, we would work through with medical schemes and providers in the private sector to understand how best the NHI package will be developed and what medical schemes will cover. So I think over time we'll be having many conversations about how it is that complementary cover will be developed and designed to make sure it's something that makes sense to everybody.
Thank you. I just want to follow up with another important issue around the future role of medical schemes. The NHI Bill also includes an amendment to the Medical Schemes Act which precludes the Registrar of Medical Schemes from allowing medical schemes to cover benefits which overlap the NHI. What does this mean? Particularly, can you explain how this will impact the status quo of private medical schemes? Does this section not contradict Section 8 of the NHI Bill?
Yeah, I think the Medical Schemes Amendment Bill was developed at a time when we had the draft legislation. I think we've now revised the NHI Bill, but what we have not done is revise the Medical Schemes Act. So I think in revision of the Medical Schemes Act, we'll have to make sure there is alignment. I think the one principle that we wanted to make sure that is carried through in the regulatory environment is that medical schemes continue to exist, as I indicated, and they would be regulated by the Council for Medical Schemes. And how then would the benefits that they provide be regulated? And so the intention of that clause was to provide some detail about how that would happen. But given that we now have the NHI Bill, we'll obviously have to align the provisions of the NHI Bill to the Medical Schemes Act to make sure that they both are coherent and talk to each other and there's no contradictions.
Just to make sure, because I think this is actually quite important, and I think our doctors will be particularly interested in what this means in practice. Complementary doesn't only revolve around what is covered. It's also about how the service is delivered. For instance, if a woman is pregnant and needs the services of an obstetrician, and that will, let's say, that is part of the NHI benefits, but she chooses to use a gynecologist who might be not contracted to the NHI fund, she will then, if she has medical aid, be able to fund that through a medical scheme and not use the NHI option. Is that correct?
So I think, yeah, the regulations about how those benefits will be accessed and what are the rules and regulations about that from a scheme perspective and how the fund will structure that is something that we would have to define. And what we want to do is put together clinical experts in each of the clinical areas to come up with the treatment protocol so that everybody understands what are the benefits, how it's going to be delivered. I think that would provide some clarity then about this issue about complementary cover and what its benefits would be. Yeah.
But isn't it also true that if you follow that kind of logic, that we could find ourselves in a system where there's a high degree of anti-selection? Because the reality is I'll be paying for the NHI package, I'll understand what my benefits are, and the moment I see that I have to use this gynecologist or that hospital and I choose I don't, then I buy the medical aid package. It essentially tells me that the premiums for my medical aid are going to be much more expensive than what they are currently, because you don't have a proper risk pool on the other side. So are you not making that part of the business very unstable?
I think we need to manage this very carefully, and one of the things we need to understand is how many providers are going to be delivering a service under the NHI, and what implications that has for people that access services outside of that, and how that could happen. So I think that's why we wouldn't want to come out and indicate clearly this is definitely what we're going to do, because I think it's a function of a number of factors. So, and at the same time, we do not want to cause any harm in implementing the system.
But the way the service is delivered, by whom it's delivered, the pathways, the
That
use,
will become the norm.
that all of those issues will be part of the
Discussions.
discussions.
Yes, yeah.
Yes.
It has to be. I think
Yeah.
clinical experts, such as the clinicians that work in the public and private sector, need to participate in that process, so that we're all part of the decision about how this must happen. Yeah.
Thank you, Rowley. Globally, universal health coverage is achieved via a variety of financing models. Some of these use multiple funders and some use a single payer. We've seen recently at the HASA conference that there's actually no country in the world that can give access through a single payer model. In all the countries that were researched, private medical insurance or out-of-pocket expenditure play a role. So,
very big.
what are your views on this?
I personally believe that we should be going down the road of a multi-funder model. I think it's important to understand that a single funder is a very centralized system. It's a system which is subject to budget constraints. For example, 2 or 3 years ago, Ireland went into huge budget deficits and actually had a minus inflation on their health bill, which creates all sorts of problems. So a single funder has certain benefits, but it also has major restrictions. I think it's very clear that there are many countries where there's a single funder, but where there's big and strong private funders and insurers. What I like about the multi-funder model is that it allows for innovation, it allows for patient satisfaction, the kind of culture of looking after people, freedom of choice. The multi-funder model assumes that there will be a standard set of benefits. In other words, everyone gets the same basic care. So it's not a question of differentiated care, we get the same care. And that model is very well applied in Switzerland, in Netherlands, etc., where they're very sophisticated markets. And I think it's something that we should really consider going forward.
Thank you. Nicola, any views to add from your side?
Yes, I would agree with Rowley. I can see the intellectual appeal of a single payer system, because I think the idea behind it is to create a very large buyer and to put the buyer power in the hands of the state. However, I think that influences the level of uncertainty that we have at the moment, because that speaks exactly to the role of the medical schemes, the complementary services, the private sector. And I think that's exactly what's creating uncertainty. And I think it is worth just having some regard to the international research on this. As Rowley has mentioned, many countries where you have a multi-buyer system, which also delivers quality universal healthcare, which we want. So there's another route to get there. And I think it's important to point out, if I look at the different stakeholders that commented, for instance, on the social economic impact assessment of this bill, Treasury also stated that they would be interested more in a multi-payer system. And I understand, that's why I say I understand the idea of a single payer, but I'm not sure that at this stage that might be the best for this country. In fact, I think that's an area which still needs potentially to be debated.
Thank you. Anban, the NHI is envisaged to be fully implemented by 2026, which is only 7 years from now. But nowhere is there an explanation of what fully implemented means. How will this be determined?
In the bill, we have what we call the transitional arrangements. You will see that in phase 2 and phase 3 of the transitional arrangements, we describe a range of activities that must happen in phase 2 as well as phase 3. And the intention is that these would be the minimum set of requirements that must be met in order for us to determine that the system is now fully implemented. So if you go through the bill and go to section on transitional arrangements, you'll identify those activities. So there's a range of things that must be done, and those things are intended to prepare the public health system for the implementation of the NHI.
But I think this might be optimistic.
Well, I think, it's difficult to debate uncertainty because we don't know what the economic situation is, the way the system will evolve, etc. But we've set this as a target, and that's what we'd like to try and achieve. If we go over that, well, I mean, that's what happened. But we wouldn't want to not have a target and simply go ahead and have no sense about how and when this will happen.
Thank you. I think we can now move to funding of NHI, which is another key element that people are very interested in. So, Nicola, maybe we can start with you. The NHI Bill establishes the financing framework, but there is very little detail about what it will ultimately cost and the different financing options. What is the role of Treasury in this process, and how do you see this unfold?
Yes, that is a very important aspect. Many people have been talking about funding options and how will we fund this huge public investment. In fairness, the bill isn't there to detail the financing. We have to state that up front. So that financing will still happen. The different options will still be considered. And I think what gives me comfort is the fact that it is explicitly stated in Clause 48 that the Treasury will take the lead on this. The Treasury, in consultation with the Minister of Finance, the Minister of Health, and the fund, will determine the budget allocation on an annual basis. So that tells me that in the current fiscal constrained environment, it's also explicitly taken into consideration where they say that tax increases might come at a later stage when we are fiscally better situated towards something like that. So for the moment, the details need to be worked out. We haven't seen new costing options. The latest figures we saw was around 256 billion rand. We know that's a lot of money. The health budget would have to grow by almost 10% per year, but that detail still needs to be worked out, and it will be important to take the lead here from Treasury in order to follow what can be designed and what can be provided in terms of the benefit, in terms of what we can afford as a country, and not go too fast down this route.
Anban, do you perhaps have any news on when the discussion document from Treasury will be available?
No, I can't give a date. I'm not sure when the document will be released, but I think what Treasury is doing is they're working on a funding model which revises what they published in Chapter 7 of the White Paper. And the intention is basically to revise that model in line with the current bill as well as the economic situation. And so I think they would provide clear guidance on what are their options in terms of taxation, in terms of the equitable share allocations, etc. But I'm sure that they would be releasing it fairly soon.
Okay, thank you. Linked to financing of NHI is the issue of the tax credits on medical scheme contributions, and there is a view that this will be phased out or could be phased out over time to create additional sources of funding for the NHI fund. How do you see this developing going forward?
I think this as well, Treasury would be making a call on how the tax credits would be reduced. My understanding about their thinking is that they would be reducing the tax credits in line with the availability of benefits under the NHI fund. So the two would kind of be running in parallel to each other. So there's no intention to reduce the tax credits immediately over a short term, but to phase them out slowly and at the same time build up the NHI fund and its available services.
Nicola, the one big risk with phasing out the medical scheme tax credits obviously is the regressive implications of this. It might actually impact the people who are already struggling to afford medical scheme membership.
Yes, of course. So that is where the detail becomes important, and the design of the tax system. The last thing that you want is this to be anti-poor in terms of implementation. But just in general, if you want to spend this amount of money in providing healthcare, then you've got different options. So there will be money allocated from the general tax pool that we know towards the Department of Health. But I think the worry is around affordability in terms of the medical scheme tax credit. But in addition, if you now introduce a surcharge tax on personal income, or even a payroll tax, which will become mandatory, then if that is coupled with high medical scheme premiums, as Rowley also indicated, if the risk pool reduced, then clearly that would have a negative impact on your disposable income. So again, it's very important that this is done in a responsible manner. Ideally, one would, over a long period of time, want there to be a real alternative in terms of the NHI before you start removing tax credits or introducing new payroll taxes or surcharges, because the current fiscal constrained environment is certainly at the moment not conducive to extra tax, and I think government is aware of that.
Thank you. Rowley, one of the key changes in the NHI bill that will be introduced is the purchaser-provider split, similar to what we have in the private sector, where different medical schemes purchase on behalf of their members from private sector providers. Currently in the public sector, we have a budgeting system and money is allocated to the providers. What are your views on this significant step?
Well, there are two major issues that we have to consider. The one is that in the reality, because the purchaser and the provider both report to the Minister of Health, we in fact don't have such a strong purchaser-provider split as is envisaged. One would want to have total independence, total neutrality, if you really wanted the purchaser-provider split argument to work well. What is interesting, though, is that the private sector is well versed with this model. We understand the functions of negotiation, of setting benefits, and of defining services. It's not so in the public sector. So can you imagine, for example, let me take a public hospital. They currently get a budget amount which is given to them every year. It comes monthly in money, but it funds their salaries, it funds most of their fixed costs, with a little bit left over for the variable cost of food and medicine and so on. That system doesn't guarantee volume. It doesn't need to produce volume. It can have one case or 500 cases, but volume doesn't really play an effect in that model. Now we're changing that model for the public sector. We're now saying to them, you're going to get paid on a DRG basis. Now suddenly volume becomes highly important for them. So can you imagine a hospital where there's low volumes and a DRG? They might in fact not be able to fund their salary bill every month, and vice versa. There's also the adverse risk that go with this. For example, in Sweden, many years ago when they introduced a DRG, hospitals that were doing very little work suddenly said, well, if we do more work, we can get more money. And so they started to do greater incidence of care. So there's a huge complexity in moving. It's not something that's very easily done. I think it's a question of what the systems are that go with it. Is the management training there? Is the capability there? So it's a huge undertaking to shift to this model of thinking.
But fundamentally, it sounds like the right thing to do.
The principle of purchaser-provider split is a good concept, provided we have the neutrality.
Yes. Thank you. Anban, our interpretation of the NHI bill is that there is a strong emphasis on primary healthcare benefits. Is it likely that benefits will initially be focused on primary healthcare?
Yes, our modeling currently in our planning is looking at primary care because we believe this is a critical part of the health system. If primary care works well, all of the other levels of care can be far more effective than what they are currently. So much of our thinking, our design, etc., is focusing on primary health care and the benefits that primary health care should offer, so that over time this becomes the heartbeat of the health system as such.
Thank you. A follow-up question around pricing. Now that we've discussed the benefits, the bill speaks of a pricing committee, and at times the bill refers to prices that will be determined, and then also sometimes referred to negotiated prices. Will prices be determined through a negotiation framework or unilaterally?
I think there would have to be regulations that clearly spell out the way prices will be determined. But if you look globally as to what's best practice, it's important that when you're a large purchaser, you understand what are the costs of delivering a service, and then when you negotiate with providers, you understand that you need to come up with a fair price that keeps the market sustainable and affordable for the purchaser. So there certainly have to be negotiations in that process, and with finalization about what would be a reimbursable price for a service.
But it's true that the NHI Bill, as it stands now, doesn't really define the structure that you need for that. So, for example, in the UK, you have a company that does the group a costing model and inflation model. None of that structure is defined at all in the bill, so it's very vague at this point in time. Is that right?
Yeah, so the intention is that we would put that in regulations, and we would define the structure and how that would potentially work in regulations. And so we'd obviously go out to consult when that happens. So we didn't want to put all of that in the bill, simply because if you write in a bill a structure, it becomes a fixed structure on which you need to work, and sometimes markets change and you need to adapt to the situation. So we thought putting that in regulations would probably be much easier to manage, because we may need to change it from time to time depending on how the market responds.
Thank you very much. In terms of sections of the bill, for example, the phrase selective contracting from private providers is used. What's the thinking behind the contracting with public and private sector providers? Because that's a bit unclear at the moment.
So the intention is to contract providers to deliver services based on the need in a particular population. Selective contracting is done so that we can make sure that everybody has access to services. So if we had a provider that can deliver a service in another area, we would want to encourage that provider to take up a contract in that area, rather than having to compete in an area for a service where there's already one provider available. So I think those are some of the contracting arrangements we'd like to engage with one-on-one with each provider, because there may be instances where we'd want to do that, given now that the way the market is currently structured, everyone's concentrated in areas where they're medical scheme members, bearing in mind that under NHI everybody technically has a medical scheme, if you can call it that. And so under that environment there's no need to compete only in the areas that you're competing now. There's opportunities in rural populations, etc., where there may be some very useful service delivery that can happen there.
So in principle, a doctor in private practice will be able to contract with NHI and see NHI patients, but also still see private patients, self-paying or insured patients.
Yeah, I mean, a private doctor would basically have the opportunity to participate in the NHI in contracting, and he or she may choose also to see private patients or see these patients but deliver services that maybe the fund is not reimbursing, for example, would be another option, clearly.
One thing that we also want to clarify is whether it will be mandatory for patients to register with the NHI fund as users.
So every South African, by right of being a South African, has basically entitlements in terms of the NHI. So the database of the Home Affairs Department keeps all this information about South Africans. So everybody is technically registered. So what our intention is for people to identify who is your primary care provider that you intend using when you're going to access services. So which GP will you use, which pharmacy, dentist, etc., and to register with those providers so that we can then contract with those providers with the understanding that this would be the potential population a particular provider will service. So it's not obligatory, but you would need to obviously register with somebody if you want to access services under the NHI. Yeah.
So if I follow our conversation to this point now, and thinking back about the complementary role of medical schemes, determined not only by the benefits that are offered, but also by the selection of service provider, the pathways, etc. Theoretically, if I want to belong to a medical scheme and I want freedom of choice, I want immediate access, I don't want to register with a specific NHI service provider, I can actually opt out of using the system. I understand that I won't be able to opt out of paying whatever taxes are raised by Treasury, but I don't have to use the system. And if my doctor is not contracted to NHI, he or she will not be obliged to contract.
Yeah, I mean, no doctor is obliged to contract in, neither is a patient obliged to use the NHI service. Yeah. But we obviously envisage that we're developing a service that doctors would contract in as well as patients will utilize. Yeah. And so our intention is to obviously encourage people to do that, and where there are problems, we would want to resolve those so that people actually access the service and providers contracting.
Thank you very much. Nicola, there are obviously challenges around not only financial but also human resources to service the patients that will be covered by the NHI fund. Can you maybe give us some perspective on the HR resource constraints and any other constraints that you might foresee?
Yes, I think it's exactly what we talked about previously. The devil will be in the detail. So while this primary focused system, again, is an appealing one, and it makes sense, one should roll out primary services first. The problem I foresee also from an economic point of view is if one thinks about the supply side of the market, it's both the facilities, so the hospitals, and the doctors and all the other providers. One would also expect to see an increase in demand. If suddenly everybody is insured, technically, then that would also lead to an increase in demand. Now, you have to be able to supply that sustainably. The fund tells us that they will contract with accredited suppliers. Now, just in terms of hospitals, we've seen in 2016-17, we have the Office for Healthcare Standards and Compliance, and only 37% of public sector institutions at that stage was compliant. It doesn't mean that they can't become compliant. It's just that I see quite a challenge here in terms of accrediting public hospitals that you want to deliver service. The same for this primary driven system will clearly depend a lot on nurses being available. So again, there's an issue here, especially a specialist nurse, but also in terms of what you refer to, the distribution between rural and urban. At this stage, rural nurses are also in short supply, similar to urban centres, and that will need to be solved. The private sector also indicated that they would like to train doctors, so that might be a way to increase supply. But again, there are all these kind of loose pieces of the puzzle that need to be put together in order to deliver this system, and it certainly will be a huge challenge from the supply side and I think the demand side.
This is actually a very important point to actually raise, because in South Africa, the average consultation per patient is about 2.3, 2.4. The OECD countries are 6.5, 7.7 sometimes. That implies that you actually need 2 or even 3 times the number of people, or you need a much more efficient system. So it really talks to a huge shortage of human capital. And in the social compact, when we had the discussions, we looked at something like a 40 to 50,000 number of nurses short. Never mind the skill sets in the various levels, but actual physical numbers. So this implies a huge investment in training, education, and that sort of thing before we're really going to get off the ground.
Absolutely. I think there's a lot of literature here on unmet demand. I think the Thai system, for instance, shows that the moment they rolled out, there was a huge increase in demand. So one expects this spike, and again, I think it should be catered for.
Yeah, I think we also need to think about whether we would want to deliver services using the traditional model, or whether there are smarter ways of delivering services. I mean, if you look at the way the UK and Canada have introduced alternative mechanisms such as the Babylon system, where people can access care through their mobile phones and contact a doctor and have a consultation, and no need to go into a health facility. That takes off a lot of the pressure on health systems and the need for so many health professionals like we do currently. So I think thinking about that, as well as what I would call mid-level workers, the community health workers and other levels of workers, could certainly ease the burden that the high-level professionals are delivering currently.
Exactly.
But Anban, that's very important then, because what we need to then understand is that we have to be changing the HPCSA rules before we can go to that. So there's like a step before that to get there, because what you're describing is the team approach.
Yes.
And right now we can't operate in teams, we can't take money in teams, etc., etc. We can't develop alternative reimbursement models efficiently. So it implies that there's other steps that have to happen before you can develop these new models.
No, I think certainly as we become clear about what the structure of the model is, we'd certainly be engaging with the councils to make sure that the country is able to actually have that model in place without ethical rules as barriers or anything.
But also,
like that.
just on Rowley's point, I think that also takes us back to the different policy processes, because if you look at the Health Market Inquiry report, they also advocate changes to the HPCSA rules, and specifically around integrated care delivery, to address issues like supply-induced demand. So you almost want to give the private sector the opportunity to also develop those systems and not just overtake that by implementation overnight of the fund. So I think it's also a timing issue.
Sure.
Yeah.
Thank you very much. Nicola, maybe a last question from my side before we look at all the questions that we've received from our viewers. The NHI Bill makes it clear that the NHI fund will be exempted from the ambit of the Competition Act. What do you make of this specific issue?
Yes, so I think at the end of the bill, I don't know how many acts are listed, Anban would know better.
12.
12. There are a number of acts that would need to be amended in order for the bill to function. So I think, again, that gives some indication of the timing and the steps that need to be taken. But the Competition Act is one that actually concerns me, because I can understand that the Competition Act must be amended because doctors who are currently competing, for instance, would now have one price being paid by the fund. So that could be interpreted as price fixing. The problem for me is that we've now had, since 1998, 21 years of very successful competition application and law in this country. So you have a host of pricing provisions, for instance. The fund will be a dominant buyer. The fund, for instance, should not be able to pay a predatory price, something which is below the cost of the supplier. So it seems to me if you exclude the whole fund from all of these provisions, you might lose something of what we've gained in the past 2 decades. And that is a concern to me.
Yeah, I mean, that's something I think we'll probably want to engage on. The advice we received was that given that the way the fund will be negotiating and setting up tariffs, it would be more appropriate that you protect those that you're negotiating with, the providers, from the Competition Act. And so this provision was intended to do that. But I hear your point, and I think maybe we'll...
Because that's only that's only Section 4.
Sure,
yes.
So I think maybe we can I mean, take that as something to discuss further and understand whether the entire Competition Act should be amended or particular clauses.
Thank you. Ladies and gentlemen, we've literally been overwhelmed by hundreds of questions. Unfortunately, we will not be able to deal with all the questions in detail, but we will definitely put a process in place to answer your questions. And Anban kindly indicated before we started that he would like to receive all the questions because his department would like to respond to all the questions and specifically to any concerns that you might have. We've also been informed, ladies and gentlemen, that our National Minister of Health, the Honourable Dr Zweli Mkhize, might join us for the second part of our panel discussion. He's been in Parliament today and he was not sure whether he would be able to make it. So if he can arrive in time and make his way from Parliament to Stellenbosch, he will also have a message for all of us when he arrives. We plan to take a break at approximately 7 o'clock, and we'll keep you updated on the possibility of the National Minister of Health joining us a little bit later. We can then move and start discussing all the questions that we have received. How can we have equality in healthcare in such a polarized society? People want water and food, not healthcare. I think a very valid comment, but Anban, the whole foundation on which NHI is premised is the one of social solidarity.
Yes, and equity. And I think water, electricity, and all of the other basic services are obviously a fundamental part as well, and so is healthcare. So the intention is that all of those services should be part of a basic system of delivering care.
Thank you. A simple question. After 2026, will I lose the freedom to consult my doctor of choice if he or she is not contracted to the NHI?
The short answer is no, because you're not obliged. Your doctor is not obliged to contract. Neither are you obliged to use the NHI doctor. You're free to consult that doctor on your own.
Hello panel, thank you for your input. In light of the country's history of corruption, how will NHI protect against this?
Well, there are various measures in the bill about how corruption should be addressed, and it's identified as one of the key risks in terms of managing such a large fund. We have a number of proposals in the bill about how that should be managed. But we're hoping through the public consultation that there would be useful inputs on what other governance measures are necessary for us to manage a fund of this nature, noting that the risk of fraud and corruption is a problem in the public sector and also on the private sector side to some extent. And so we'd want to understand how best we can do that going forward.
Thank you very much. Will this discussion be available on video for doctors that were unable to attend? The answer is yes. We will definitely make this available. It is being recorded. Where will the doctors or specialists come from to accommodate all the new patients? What will be different to the current public health system? I think we touched on this, and
yes.
Key to this, I think, is the development of alternative delivery models.
Yes, exactly.
And then we emphasize the importance of training more people, more healthcare providers. Will practice cost inputs be considered in the reimbursement tariff process of NHI? This is from Dr. Pillay at Medforum.
Yes, certainly. I think practice cost information is critical in determining what the reimbursement rates will be, because what we don't want to do is reimburse at a level that's inappropriate, both too low or too high.
Then there's a comment that says this discussion is pointless if the panel dodges all the questions. But I don't think we have.
I haven't dodged any questions.
Who's that?
Anonymous. Once NHI is fully active and private hospitals are being overwhelmed by a doubling of patient numbers, are you going to transfer doctors from the public hospitals to cope with the numbers?
Well, I mean, we'd have to get to that point and talk about what the solutions will be in terms of managing patient numbers, yes.
An interesting question around the NHI pilot programs. Why do you think that the NHI will succeed if the NHI pilot programs have failed?
Yeah, I think I'm not sure where that story arose, But the projects that we were busy with, they were in the NHI pilot districts, but they were not NHI pilots. The NHI pilots could only be implemented once the financing system is in place. What we had is what are called health system strengthening projects, and they were like bringing in GPs to work in our clinics, developing a centralized chronic medicine distribution system, etc. So there were a number of those interventions. The report relating to those interventions are on our website, and the independent report indicates that all of the projects should continue. They were successful in many areas. Where there were problems, the authors proposed some interventions to fix them. So I'm not sure where the story about the failure comes from.
But you're referring to the Genesis report?
That's right. Yeah.
Yes, because I think that report is fairly balanced, but they do point out some problems there.
Yes.
So I think it is not correct to say on average they failed, but I think there are some pitfalls that were pointed
so
out in
certain
that
districts
report.
we had problems with the way the service was delivered, because maybe the human resources on the ground to implement it were not there. So it wasn't the design of the project, but the implementation in certain districts. And I think the advice to us was maybe you need to implement these other things before you implemented that in these districts. Because what they did identify was areas where it did well and areas where it did badly. And so they focused on the areas where the districts where they didn't do well, and to understand, well, why is it that it didn't do well here, but it did well in another district?
I see.
So we are being accused of dodging questions. So there's a question here. Please give a clearer answer. Read the pregnant patient and private gynae. Can the patient choose a private service provider or not? Thank you.
The patient can, the private gynae, if he's available and the patient wants to go to the private gynae, he or she can do that.
But one should potentially talk about the cost.
No, but let's talk about the reality. That other clause that Koert referred to talks about the fact that the registrar will come along and say, if this is a service that's been done in the provincial hospital, then I cannot have it in the medical scheme. So then it means that I can't get insurance for it. I can pay for it, but I have to go and pay for it in a check or credit card out of my bank. I can't buy an insurance product for it. I think that's important.
Yeah, I think it's important not to kind of pigeonhole the discussion in that way, simply because given the way the service coverage is, in other words, for a particular service, if we can get public and private providers, public and private facilities, then I think the argument about choices is not there. I think where the service provider is only the public sector, there's long waiting times, etc. There may be challenges. That's why we're saying that the minister will make those regulations. At that point in time, he will make a decision about what is it that actually should happen. So if we made that decision now, in 7 years' time, the market changed and there were differences, then we're stuck with a particular situation. So we think it's important at that point in time to make the decision about exactly what services will be covered and what would not. Yeah.
Now, I still think it's a worry for the average patient, because it's fairly well known that, for example, in the UK, in Australia, etc., that if you want to go for a cataract, your waiting period is 5 months. If you want to go for hip replacement, it's 8 months. It's sometimes in some of these countries, it's 18 months. So I think it's a reality in a country that is rich, well-funded, got a well-structured model. There are already these waiting periods. And if you're going to say to me, because it's done there, I can't get it outside, then it's really going to be problematic. So the UK, for example, says, I can provide it, but then you wait. If you want to go outside, you can get it, but then you pay. Now, if we can get that clarification, then it's fine. But we're not reading that into your bill at the moment.
But also the assumption is obviously that it's going to be equal quality.
Yes.
But the problem is that I think Rowley's point is that most people in the worst case scenario would then have to bear the burden of both the tax in the interim period.
And fines.
Exactly, and still pay my medical scheme while that is possible. And then in the worst case, when it's only complementary and I cannot get it from my medical scheme, then I'll have to pay for that completely out of pocket. So I think the point here is, it is optimistic to think we're going to have perfect choice, and it would be fantastic if one day we have perfect choice. But I think we have to think about the sequencing of these issues. And I think to Roli's point as well, the private sector can play a very important role in solving many of these issues. And I think that is the concern of trying to say, well, it's restricted, for instance, to complementary services. So it does sound like, the private sector is being relegated in a sense, which I think in your introduction you said you don't want it to be.
Yes.
But I agree with Roli. That is the essence of the uncertainty here.
I think defining these issues and the complexities of them in a bill is kind of fixing the way this issue can be solved. So for that reason, we've put them in regulations, and I think the time will come when we need to discuss them and debate them. And I think when the minister then makes those regulations at that point, we would have had a clear sense about how the system is operating, about what would be complementary cover, what would be the quality of services under the NHI, etc. And then people will have a clear sense about that. And so would the minister when he makes those regulations. Because if we made that call now for something that's going to happen in 7 years' time, I don't think anybody would be clear about how that would happen, right? And what the quality would be. And so it would be much better if we did that at that point in time. Yeah.
Unfortunately, I think this whole situation is creating uncertainty.
Very much so.
And from all the discussions that we've had with private healthcare providers, including our independent supporting specialists, all of them support the vision and what the NHI wants to achieve. And all of us want to be part of the solution going forward. And I'm convinced that most doctors, all our hospitals, are prepared to be part of the solution and deliver services, but people also want to know where they stand and they want to plan for the long-term future. The next question, for instance, or comment is the uncertainty is driving doctors out of the country. What do you do to give us more certainty for the future of doctors in South Africa? And I know it's not the intention, but the uncertainty is really problematic at the moment, and to say that we'll have the regulations in 7 years' time unfortunately does not help to alleviate the uncertainty.
Yeah, I think people need to understand that we're developing a new system, and in developing the new system we need to understand how the market will respond, the way the benefits will be structured, etc. So any new change will come with uncertainty, and I think we need to hold hands and go through this process together. There is no intention to cause adversity for doctors for them to want to leave, because even if they wanted to do that, I think at this point in time it would not be a choice I would make personally, so given the options that I would have. So I think we need to have conversations about exactly what are those challenges at that point in time and see how we solve them, rather than being afraid about them.
We've received many questions around the role that doctors can play. Will a specialist be able to see both NHI as well as medical aid patients? I think we've covered that. How will private practitioners involved in the NHI be reimbursed? I think we talked about the pricing committee. We talked about governance and corruption. These are themes that we pick up on many of the questions. I thought all South African citizens do currently have access to medical care. Nobody is denied care in the state sector. So I think the point being made that we already have some form of universal access to healthcare.
Yeah, I think access to a service and the quality of the service and the type of service that people have access to is the issue, not just that there's access. Yes.
Medical schemes will not be allowed to pay for primary health care. Will all the healthcare providers in primary care be given contracts or permanent jobs with the NHI?
So providers will choose to either work within the public system if they choose to, or they would be contracted in to provide services, and that would be their choice. But all providers would have the opportunity to contract in at primary care and at hospital level care as well.
Maybe just if I can say, on that issue of access to healthcare, I mean, that's correct. everybody has access currently. So what they don't have is access to quality healthcare. So
Yes.
the whole aim of this is to improve quality and equity across the systems. But we've heard, there was, I think, a 9-point plan. There were different plans of increasing services and quality in the public sector. Is that going ahead in the interim? I mean, is there maybe something you can comment on in that sense?
Yes, so there's the Office of Health Standards Compliance, and there are internal quality assessment tools. What we didn't have for a long time in the public sector was a minimum standard set that all facilities must meet. What we came up with was the ideal clinic model, and now we have an ideal hospital model as well. And the idea is that every facility should meet those minimum standards. Those facilities that do meet those standards then are eligible for contracting. What's happening now is that public facilities in each of the provinces, the provincial departments are doing assessments of whether these facilities meet these standards. Where they don't, they've come up with plans about how they would get there. And so over time, we will see an increase in the number of facilities that are compliant. And so I think this would be a gradual process between now and 2026, where you'd see more and more facilities actually achieving the targets in terms of that.
Sure, and the fiscal requirements then obviously would have to be met
that,
in terms of the allocation.
Yeah.
I should add that private facilities will also be inspected, both your
Yes.
establishments like hospitals, but also private providers like GPs and dentists and pharmacists, etc. Yes.
Right. Another interesting question regarding funding of NHI. We talked about the tax deduction, but this question specifically asks, when will the tax deduction start? Will it be before 2026?
Our understanding is that the tax deduction would happen at the same point at which the NHI is fully implemented. So I would anticipate that would happen at 2026 in terms of the current timelines. Yes. But I think Treasury in their financing paper will provide more detail about exactly when that will happen.
Thank you. Obstetrician income will decrease as deliveries will move to primary care. Will government help with obstetrician insurance, which is about 1 million per year?
Yes. So currently the way our insurance works is that if you work for the public sector or deliver a service in the public sector, we take the insurance risk linked to that. And I would anticipate that under the NHI would continue with that model of managing risk.
Then another interesting question on which we haven't touched: how will non-registered patients, non-South Africans, be managed?
So the bill describes the entitlements of different categories of people living in South Africa, rather. And so if you're talking about illegal migrants or asylum seekers, they're entitled to emergency medical services. They're also entitled to care for notifiable medical conditions and basic health care for children. So services that fall outside that category would have to be self-funded. And where you have tourists and the like in South Africa, they would have to take some sort of private health insurance or medical scheme cover for that.
There was a specific question: are you going to limit a private doctor to a geographical area of practice through the certificate of need?
We, in the bill, have not made reference to the certificate of need. We think that through the contracting process, we can achieve the objective of what the certificate of need was trying to do through a different mechanism of contracting, rather than having to limit people in the way the certificate of need does, yes.
We live in a unique and wonderful country, but 8 million private medical aid members cannot fund our population of 50 million plus.
Yeah, no, I think that we would agree with. I mean, if you did the maths, it's very clear that you can't. But I think what we can do is get to a system that's different in terms of the service delivery platform. So I don't think we can ever use 8 million people to subsidize the rest.
But that's also not the correct comparison, because the tax base is larger than that. So it's not only the medical scheme patients. I mean, you have to bring everybody that's currently in the tax base into
Yes.
support of the fund. So you can't compare just the one with the other year.
But I think our tax base is actually small.
No, it's small, but it's
Yeah.
not only
Personal
the
income
medical
tax
scheme.
is small,
Yeah.
Yes.
but the tax base is much broader than just
The
personal-
medical
yeah,
scheme.
yeah, there's
Yes.
other
Right,
options.
yeah, yeah. Welcome back, ladies and gentlemen. We are indeed very privileged. During the break, our Honourable Minister of Health joined us, and it's a big privilege for me to welcome our National Minister of Health, the Honourable Dr Zweli Mkhize. Minister, thank you very, very much for travelling all the way from Parliament to Stellenbosch. It's our privilege to welcome you to our corporate office. Thank you for the interest that you have shown in private healthcare, and specifically the concerns of our specialists. I also saw on Twitter that you announced that we are hosting this panel discussion this evening. During the first session, we talked a lot about the NHI fund and all the structures and how the fund will be financed. And we've been inundated with questions from our viewers, all our supporting doctors and our management staff at our different hospitals. And I think if I can summarize, the biggest concern at the moment in private healthcare is the uncertainty. The NHI Bill is enabling legislation, but the detail around what benefits will be covered, how the NHI will be funded, how contracting will work with the public sector and the private sector, the future role of private medical schemes, those things are not quite clear at the moment, and the uncertainty is unfortunately often causing negativity amongst our doctors. And what we want to achieve this evening is to give the correct perspective. I know we don't have detailed answers to all the questions, but it would be very helpful and very valuable if you would share your thinking with us, and specifically your thinking around the future role that private healthcare can play in the NHI dispensation.
Well, thank you very much. Indeed, we thought that it would be important to just come and be part of the conversation. I think the first thing to say to most of the doctors and the health workers and public out there that it's early days on the NHI issue. What we're looking at is a framework legislation that's going to enable us to move on with the dispensation of the national health insurance. I think all of us have discussed the fact that this is one very highly needed reform in the health services, particularly on the fact that it's actually now issue of universal health coverage is a whole global movement, and every country has to look at it. It's also in line with the Sustainable Development Goals of the UN. And so we have to actually move in that direction. But also in particular, we have to find a way to improve the health services in South Africa in general. And so our approach is that whilst we're setting up the national health insurance, we're actually also fixing the public health services. The issues of infrastructure that has to be corrected. At the end of the day, the infrastructure has to be good in such a way that you shouldn't be able to make a distinction between public and private. It might sound like a very ambitious issue, but in fact, we have to be ambitious to be able to achieve it. The issue of staffing has to be corrected. The issue of supply of medicines, all of that has to be corrected. In the next 5 years, that our major focus is on setting up the NHI fund and setting up the structures that are going to be associated with all of this. But we have also indicated that once the NHI is been properly set up, that at that point we'll be able to have a conversation about the exact changes that will be affecting the medical aids. We don't have right now, as we speak, something that says that medical aids this and that is going to be happening, other than just to say that we're hoping that the NHI should cover access to all the people, and that of course the medical aids will continue to exist, but in the way they would exist, the scope of their operations and the roles and so on will obviously have to be adjusted at the time. As we sit here today, the nature of whatever changes that would be necessary at that point has not been determined. The whole issue around benefits, we're going to be maybe in another 2 or so weeks, we'll announce the team that's going to be guiding us. We're going to be getting all specialists, both public and private, who are going to be looking at what services should be covered, what services should be rendered under the NHI. That is going to be basically based on what we call the clinical protocols, the guidelines. It's going to be a guide that will get from the heads of specialist disciplines that will get us that kind of approach. Some people have actually thought that when it said the minister will do this, they thought that, well, somebody's going to sit down and say, well, you get this, you get that. In reality, it's really, all of us know that health services are very highly specialized service. And because of that, you're not going to get everyone determining what's going to happen. We're going to only get those who are in charge of those services, of those particular disciplines, who are going to say to us, this is what we believe needs to be rendered, as it were. So the approach basically is going to be that. The fact that we're going to implement this in a phased manner, we believe that as the time goes, we will be able to convince anyone that really this is something that's going to be workable, that in fact there should be changes in the public health sector as we move on, so that all those who are raising the concerns about the quality of health services, the problems of corruption, which we actually take very seriously, that we should all be working together to try and create a system that would be perfect for all of us as South Africans. It is something that all of us are aware that most of the countries are going have it. Those of South African doctors who have moved to work in Canada would tell you that they found that the system is working in Canada, in the UK, in France, in Germany, in Japan, in Australia, etc. So those are the issues. Then in terms of some of the details, obviously as we move on and as we consult and engage, a lot of those details will be dealt with and clarified and so on. Right now we're at a point where we're dealing with a framework legislation largely, and then of course over a period we will be able to deal with that. Somebody is asking the question about how the private sector, particularly the hospitals, will be affected with this. There are two things that we would say. Firstly, that the private hospitals, will not just be pulled into the NHI, willy-nilly, as it were. There may well be instances where they'll continue to operate the way they're operating, but where there are areas where the government has got challenges and requires, in the context of the totality of the services that are needed in a particular area, the private hospitals will then be contracted, but obviously it's them who must agree that they will be part of it, and therefore then the issue can be discussed in that kind of way. Then I saw a question here about issue of 5 million Zimbabweans in South Africa. Again, here, we are facing a very difficult situation. The bill on its own basically provides for provide health services for South Africans and for those foreigners who are here on basis of legitimate resident permits and so on, or those who have been granted asylum. Now, anyone else who is not in that system or who is not in that group, those categories, will only be treated on the basis of emergency medical care, as well as on the basis of notifiable diseases. Now, in that case, what it means is that you walk into an area, then as South Africans, you will actually have been registered. So you will say, I'm Zweli Mkhize, and then of course, this is how I identify myself. Then we'll identify you as such, and then we can then look at you from that point of view. Those processes of registering those people who will be beneficiaries beneficiaries who are working within the system is actually quite advanced. At the moment we've registered almost 42 million of those, and in the process we are verifying probably another of those 42, 32 have been properly 32 million has been properly verified, and we're going on with the rest. But we're also wanting to use Home Affairs so that there's an alignment between what is the citizens register and what is going on, so that people don't fall into cracks, and then the children will be born, will be registered as they grow. So let me just say at this point, if one can just hold it at that, we can then look at some of the questions as they arise.
Yes. Thank you very much, Minister. That's been very helpful. Maybe from our side, I can reiterate that we want to position ourselves as part of the solution going forward. We don't want to see a future where private healthcare is isolated. We are part of the bigger healthcare system, and we have a particular role to play, but we are also willing and able to assist the public sector, contracting with the NHI, looking after some of the additional burden and assisting the public sector. So we will be very interested in open engagements and working with you and your department to collectively find the optimal solution.
Thank you. Thank you very much.
Yes. Minister, maybe if you are still available, we can then look at some of the questions. Here's a very interesting question, a very personal question. Please ask the Minister if he has a medical aid.
Okay.
Changing the model of healthcare will not compensate and remedy the consequences of a poorly run state health services fraught with corruption. I think we've touched on that, and you reiterated the importance of refurbishing public healthcare hospitals.
Yeah, I can just add a little bit here that, the issue that's been raised about corruption, we actually believe that South Africans are seriously concerned about it, and therefore it's something that we have to face. We have said that as part of what was discussed as part of the social compact with the President, that we're going to need a structure that will oversee the health department, particularly the NHI, that will constitute of some civil society bodies as well as the special investigation units, the Hawks, who will actually be there to monitor in the case of any corruption that's happening, that also use the same technology. That the banks have got very interesting technology these days, where once you touch and there's a transaction, it reflects somewhere, and somebody must confirm that they actually agree with the transaction or not. And you can track it. You can even reverse it. You can stop certain things from happening. We are ambitious to actually get that kind of technology here, because when you sit here and look at the news and what has happened and so on, I think people do get discouraged. But I must say that we actually have to learn from this and go forward and deal with it. And yes, I've got a medical aid.
Thank you, Minister. One thing that has been discussed over many years, and that is of particular interest to us in the private sector, is the question of public-private partnerships in different areas, in service delivery, in training of healthcare professionals. Unfortunately, we did not make a lot of headway previously with public-private partnerships, but we still believe it can play a huge role to assist the public sector. What are your views on PPPs?
I think that public-private partnership remains open. It's a question, obviously, of what makes business sense to all of us as we are involved. Let me just say, way back, we'd actually tried to encourage a lot of refurbishing of the hospitals and creating space for even private paying patients, so that you can actually share those, and then it actually would help to lift the quality of care on the one side, but also create the necessary competition and all of that. I think it may not have happened in the way that we necessarily would have wanted it to happen, but going into the future, I've indicated how there could be a space for public-private cooperation in terms of the hospitals. That's an issue that will obviously be open, because where there's an oversupply of beds, then there may not be much need to actually engage the private sector. But then where there will be an area of inadequacy of beds, you should consider a possibility that rather than going to look for creating a new hospital, building a new hospital, maybe depending on how this gets done, because then of course when that happens, obviously the state might come and say, we're going to be doing so many of these operations, and then negotiate the price, and then that's the issue, and that it remains a possibility. The private practitioners, what would be engaging more in the immediate term is going to be the general practitioners, the family practitioners, and in a number of areas we're actually approaching them to say if they would like to participate. Obviously there's a lot of clarity that is needed at that level, but at that point we're going to be needing to work with them as a part of that primary healthcare network system. In some of the countries, most of the general practitioners and private are actually working within the system, and there's quite a lot of willingness from the private practitioners to engage and participate in that. We're going to be engaging them on that. When it comes to others, such as pharmacists and so on, we envisage that there'll also be some participation and some roles. We met with Independent Community Pharmacists Association. They've actually said to us, 3,500 outlets and 20,000 staff, we put them there available for the NHI. These are the programs we'll be interested in, and so on. And we said, okay, let's start the engagement and let's see how far that takes us. In the immediate sense as well, we're looking at the issue of rebuilding the government public sector infrastructure. You've got a huge number of hospitals that need to be refurbished, to be replaced, and all of that. And the quickest way of getting that is where we create a public-private partnership. Because from where I sit, and we've looked at the figures, we think it's possible that government can have all these hospitals built and refurbished in a space of about 5 to 7 years, and then get the benefit thereof whilst we negotiate. We're working on a negotiated repayment plan for it. We've done some of the public-private partnerships. When I was MEC, we did one of the biggest hospitals, which is in Nkosi Albert Luthuli in Durban. It still stands there as one of the best examples of this kind of collaboration. So there will obviously be areas where we could actually find space to cooperate.
Minister, if I may just follow up on the public-private partnerships, the previous models were based on a private sector involvement for the development of the infrastructure and then managing the services that we would also typically outsource, like housekeeping, security, garden services, catering, and those type of services. What we would be interested in is to get involved in managing the core services, the clinical services within in the PPP space, and where there is unutilized capacity within the public sector hospitals. It could be a model where you can put that out on tender. The private sector can compete for the space and then manage that at a much reduced cost for the public sector.
Well, yes, no, thank you. We have not obviously had to deal with that situation. Yes. I suppose that when we discuss, it's something that we'll have to look at. Is it workable? Is it something that we've got space for? But as we speak here now, it's not one of those models that we've actually had to deal with. Yes.
But I think we need to think innovatively about other models in the future. Okay. I would also like to invite my colleagues, Rowley and Nicola, specifically, if you have any questions from your side, please feel free to ask them.
Yes, I would like to ask the Minister a specific question, listening to the answers now, and I think also We had opportunity to speak to the doctors before you joined, and I think the sense was really around uncertainty. I've heard what you said, and I appreciate the fact that there's a role for the private sector. I also heard you, I think, at HASA 2 weeks ago saying you're not nationalizing private hospitals. So that is all welcome and good. I think the problem at the moment is that people are worried and they are uncertain because there are contradictions, seeming contradictions in the bill. So I have a very specific question. You now have a period for comments. Different organizations can give comments to the Portfolio Committee of Parliament. Will those be incorporated? Are issues like a single payer system, is that cast in stone? Because that does send a specific signal about the role of the private sector. Are all these things cast in stone as they are currently in the bill? Will comments be taken on board? When will the regulations come? I just want to get a sense of how this will develop and how that will impact on the private sector's position during this process.
Well, the bill has been put in a way that really deals with certain of the options that we have preferred in relation to how we've been benchmarking with different countries. And so the issue of single payer comes in that kind of context. Now, the processes right now, to be honest, as we speak, are no longer in our hands. They're in the hands of Parliament. And therefore, when people make submissions, it's going to be Parliament that's going to have to deal with the submissions that will come at that level. So people can make whatever such submissions that they would like to make. And that process, the Parliament is making a call, I don't know, in maybe another month or so.
The 10th of October.
Sometime in October, somewhere, that they will be actually opening up to take those. And I think we must just remember what tends to happen in this kind of situation. That is, you will find there will be one issue, and then there are those who are on the supporting side, that those who are on the rejecting side, and that really becomes an issue that the parliamentary process has to try and work through those issues.
Rowley, we talked earlier about universal health coverage models in different countries, and also at the HASA conference recently, Minister, there was a presentation on how these models work, and what was interesting to see, even in Canada, and various other countries where NHI type of systems, national health systems, were introduced, you still have a component of private voluntary insurance and out-of-pocket expenditure. It varies quite significantly between different countries, but it just seems part of the reality that you will need that additional funding, and there are actually many benefits to having the private funding as part of the overall system.
Yeah.
Would you maybe like to...
I think the point that we're making is that the private sector can play a huge role in that area. And I think we're probably concerned that the fact that there's a seeming limit in terms of the definition of complementary. I know it's something that's still going to come in future. I know it's not something that's available right now. But certainly the way the bill is written, there's a clear indication that some services will not be able to be funded in the private medical aid kind of world. It's just our view that if you look at all of the countries, I mean UK, etc., there are these insurance models, savings models, insurance models, etc., that give impetus to private business capacity. They create an economy around them. They build the economy, they create jobs, etc., and we think that within the context of the South African economy, that's a vital component to be looking at right now. And so we would really be looking to say, is that not something that should be considered more seriously than what we appear to see it in the current bill?
Yeah, well, I suppose that when we talk about the various models, they evolve in different ways, and in our case, it's not like we would be saying that there will be, completely no private sector is banished. No, we couldn't be able to put such a position. But the distortions in our system, I think, also do need to be taken into account. The reality is that when some studies were done and just comparing the disproportion actually in terms of the percentage expenditure from the private health side as compared to what's happening in some of the countries, it's actually quite a distortion. And that, for example, I think in the UK the figure could be around 10.5%. In our case, the distortion is causing a difficulty when you've got a 15% population cover, and then you've got 50%, 40% expenditure. So those kinds of distortions are what we're actually getting criticized as well by the current processes of the health market inquiry, to say what government has allowed is a situation where they've not really looked at what some of the issues that are important to take into account to manage the issue of the costing, and of course the dealing with the question of to what extent are you providing for health as a right as a country, which is something that is a norm in a number of countries, as it were. So the question of the role of the private sector, I think that we must take it that we will not have a situation where we just say there's nothing completely. The question is how this is going to evolve, and what roles we're going to be seeing, and to what extent. Obviously, it's difficult for us to say to you, this is the percentage participation that is going to be happening. But what we can never have in a bill is something that creates an impression that now medical aids are going to be banned, private healthcare will be banished. But the question of what is it that we're going to ultimately end up with, I think it's obviously going to be evolving, because over the period, by the time we get to a point where we say, okay, we have most of our weaknesses on the public sector corrected, and the structures are set up and so on, we'll have a very different environment when we start to discuss at that level. So I would say for me that all we can focus on now is a framework of the bill, but a lot of engagement will obviously be happening. And I don't believe that there will be a time when we'll say, well, we've had enough engagement. I think that things will keep evolving as we move on. And what we have as we start is maybe not what we'll have as we are somewhere after so many years into the process. Yes, we are watching what is going on in a number of countries. The questions of what models they are using and so on, and what pressures they are experiencing, are all the things that we're going to be learning. In the next few weeks, we're sending a lot of people out to about 5 countries. Those hospital managers, health managers at the provincial level, at national level, MECs and so on. Some are going to the UK, some are going to France, some are going to Thailand, to Turkey, to Japan, all of whom, so that when they come back, they'll come with this, assortment of different experiences, that when we sit down, we then be able to say, as we engage, what of those, helps to inform some of the things that we're going to be doing.
Yeah. No, thank you, Minister. That provides a very important perspective, and I think that confirms that we are still early on in this process, because if we are still studying models in other countries to improve our own thinking around our ideal NHI model, it confirms your earlier point that it's actually still early days. And obviously we would like to utilize every possible opportunity to engage constructively and to make a contribution. What we do pick up, Minister, is that there's a strong view, obviously from a private sector perspective, that we all support the vision of NHI and the principles of universal health coverage. But there's a strong view that once people have made their contribution, be that through additional taxes or a surcharge on income tax or a payroll tax or whatever form, people would still have the right, should still have the right to buy private insurance if they wish to do so, and if they don't want to use the pathway or the treatment protocols of the NHI fund. We often hear the same argument around education. around security, around transport, around housing. People pay taxes, government provide those services, but many people still buy private security or their own houses or private education for their children. What are your views on that specific right of individuals to, over and above their contribution to the NHI fund, with their own discretionary after-tax money, elect to take out private medical scheme insurance?
Well, I think firstly, as we have said, we are not going to be arguing about whether medical aids are going to continue or not. In our case, the model that we have put on the table is the one that basically tried to offer the cover for everyone in the country, and then that what the universal, the NHI doesn't cover, then of course that the other medical aids can cover that. So that's why we talk about it as complementary. Now, the issues in terms of how the individuals would like to look at it and so on, and some of the interpretations, I think as we engage through this process, the only way of looking at it is that some of the interpretations that come into the thing, into the meaning of some of the provisions is something that we'll have to follow the interpretation of how the parliamentary process will then be interpreting them. That's how we can really take the issue forward from there. But I think from where we sit, the main focus that we are really trying to resolve is an issue of trying to bring in a degree of equity, the degree of equal access to quality health services, and that's really the thrust of what we're trying to deal with.
Thank you very much, Minister. Any further questions, Nicola or Rowley?
No, that's all I say.
No, I think as we also previously just mentioned, in terms of policy coordination, it's obviously also important to keep Treasury on your side. And I think we welcome the fact that the bill states that the fiscal constrained environment that we are currently in is also playing a role in terms of when these taxes will be implemented. I think that was also some of the questions that came through. People want to have some idea of the timeline. And I think Anban also gave some indication. So I don't know if you have more insights just into the role that Treasury plays in this whole process and whether the benefits will be rolled out as fiscal means become available, or how that process will work between Treasury and the Department of Health.
There are two areas that we need to be focusing on. The first one is that, as I've indicated at the beginning, we will have a team that will be looking at possible packages that will be offered, and this team is not an ordinary team. It's people who are our specialist experts in various areas, and right now they'll be looking at treatment protocols, as also both in terms of what treatment regimen that we're going to need and what surgical interventions that tends to be required, and all of those together, they will then come out and say, this is what we recommend government must do, and then we'll just take it from that point. So that's the one aspect of it. Now, when it comes to the question of what packages are possible, what the possible cost of it is going to be, we're going to be sitting together with Treasury, because every time we have to look at the rolling out of the whole NHI, we're going to be sitting down with Treasury to say this is what the financial requirements are going to be, and Treasury will then sit down and say to us, okay, if that's the package and we sit here, we're going to have to make certain projections, and therefore let's calculate the issues of affordability, look at the sources, look at everything, and therefore that discussion we're going to be engaged on a continuous basis. I make an example that when we raised the issue way back, I think around 2010, and we said, look, just try and focus what is likely to be the cost. They did quite a lot of computations, and then a figure of 256 billion came around. It comes from that figure, from that issue. It assumed a particular cost of healthcare. It assumed a particular growth rate of the economy. It assumed a particular growth in the fiscus and all of that. Now, obviously, as you go, you keep changing, because a lot of those assumptions have to be changed at each and every time. But on a continuous basis, we're involved on these issues with Treasury. Effectively, what we have to be doing from health side is to say these are the preferences of health in terms of our policy choices, and then they'll have to come in and say what of this is what the cost will be, this is what the cost will be, and that's the kind of conversation that is going on right now.
I think that's wonderful. It's just that policy coordination in this country has not always been working very well. So I think it's good to hear that there will be coordination between the different departments, especially Treasury and your department.
Well, we're actually coordinating on quite a number of things. Right now, a lot of issues that we're discussing, for example, relate to how we will be moving the funds in light of the fact that there's a particular formula for allocation of funds with the Financial and Fiscal Commission looking at particular formulas, and then if we shift that arrangement, how is the shifting of the functions and the formation of the fund going to affect the shift in terms of the vertical split and all of that? So we're going through those issues with Treasury. At the same time, as we're talking about this whole question of infrastructure build, it's a joint team of the two that are looking at how quickly we can actually source in additional creative ways of financing infrastructure built, and therefore they are moving ahead. In fact, they are the ones who are leading us to say these are the possible options of what can be done, and can we then get endorsement so that we can move ahead. So there is a very close alignment in the discussion. Obviously, there's going to be areas where there's going to be debates, there'll be disagreements on this and that and the other, but we really operate as a team.
Thank you, Minister. We are coming to the close of our session. Before I close, however, I want to give everybody an opportunity to maybe make a last comment, and I'll give you the last opportunity, Minister. Nicola, anything that you still want to raise in closing?
No, I think this has been very useful in addressing some of the uncertainties. I think the information is there. It's important to understand it's the first step, as the Minister has also pointed out. So I think the detail will be important in terms of the regulations and the interactions and the debate going forward.
Yes. Thank you, Nicola. Rowley?
I just think that the private sector that we've built up over the last 40, 50 years is a crown jewel. It is worth a lot of experience. There's a huge amount of knowledge, both on the provider side and on the funding side. And I would really hope that there'd be a close cooperation between the public and the private to actually make sure that we use all of these gifts that we have to the greatest extent that we can, as opposed to keeping it into two camps.
Yes. Thank you. Anban?
Thanks. I think the NHI brings uncertainty because it's change, but I think people should not be fearful of the change. I think we need to engage and understand what are the changes and work together so that we can create a path that identifies these challenges and deal with them. Because I think the fear is about the uncertainty and the change, but I think if we engage, we'll demystify some of these things that people have.
Minister, any final comments from your side?
Yes, firstly, I think I'd like to appeal to all our health professionals, our specialists, not to, out of the fear of what might be coming, decide to leave the country. I would appeal that let's work through this together and see how we can build the best service for our country, and that those who are on medical aid, It doesn't mean that we say we want to institute NHI now, people must stop paying their medical aids. That's not what we're saying. We're basically saying that we have a framework, and then out of that, we need to actually understand that the bigger problem that we're trying to solve is inequality in the country, and therefore we need to forge a process where there's a closer working relationship, and that the system must operate as one system, although with various different components. But these disparities have to be addressed. And so moving into the future, let's really look at what is it that we can do to create the best health services for South Africans.
Thank you, Minister. Ladies and gentlemen, I want to close by firstly thanking all of you for following our panel discussion tonight. We've been inundated with questions. I apologize for the fact that we were not able to answer each and every question in detail, but there has been a lot of overlap between the different questions, and we will definitely somehow group all of this together and prepare more comprehensive answers. Then I would also like to thank all the panelists. It's been a privilege for us to host all of you, specifically the Honorable Minister of Health, Dr. Zweli Mkhize. Dr. Mkhize, I follow you on Twitter, and I'm amazed, firstly, by how many followers you have and how many people you follow. And if I look at your program, I can't believe that you engage with so many stakeholders, and that you basically work day and night, and you travel all over the country and all over the world. So you are really doing an amazing job, and we have a lot of respect for that. And the fact that you traveled to Stellenbosch because you see us as an important stakeholder is really, we are humbled by that, and we really appreciate that. And in return, we want to assure you that we want to be part of the solution. We are not against NHI. I've never picked up any negativity about the vision that you want to achieve. It's all about the uncertainty and the detail. And from our side, we feel very strongly about the rights of our patients to access our facilities and to go to our private doctors for treatment. But based on what you've said tonight, I'm sure we'll work out the dispensation where we can have the best of both worlds. Dr. Anban Pillay, Anban, thank you also for traveling to Stellenbosch and for your willingness and openness to engage. Rowley, thank you. Rowley unfortunately fell ill today. He's got a bit of laryngitis. But Anban assured him that the NHI fund will pay for his treatment. And then Nicola, as always, thank you very much for your commitment and willingness to participate. And we can see that you are really an expert in your field, so we really value your contributions.
It's a pleasure. Thank you.
Ladies and gentlemen, on that note, unfortunately, we've come to the end of a very interesting panel discussion. We've recorded this discussion, and it will be available for anybody who was not able to follow the discussion. From Mediclinic side, we want to thank our supporting doctors for their continued loyalty and support to our hospitals. We will do whatever it takes to secure the rights of our patients in the future to access our facilities, and also to choose their providers of choice. And in a spirit of positive cooperation with our Minister and his department, I'm sure that we will be able to find win-win solutions that will be to the benefit of the greater healthcare system in South Africa. On that note, once again, thank you very much for joining us. Have a good evening and goodbye.